Okay, we're going to get started. So if everybody would come on back in. Buddy?
Hello, everyone. If we could regain our composure. Once again, it's my opportunity to introduce our next presenter. And this is a real pleasure because next presenter is Tracy Crawford. Tracy and I had an opportunity to work together in a prior life years ago in Pittsburgh when I was with Allegheny, and it's delightful to see her here today. Tracy is Program Director for the ClinicalConnect HIE in Western PA. She's responsible for all aspects, the operational, the design, the implementation, 7x24 help desk, right, Tracy? We've all been there with that. And she's a graduate of Penn State, has a master's degree from the University of Pittsburgh. She's originally was a medical technologist, and prior to taking the reins of the ClinicalConnect HIE, she was with Children's Hospital in Pittsburgh, where she led the hospital to achieve level 7 of the EMR adoption model. And those of you who are familiar with that model know that there's only 30 hospitals probably in the United States that have achieved that 7th layer, which is based a lot upon the analytics ability to report on the EMR data. Under her leadership, Children's Pittsburgh also received the HMS Davies Award and a award from the Leapfrog Group for patient safety. So please join me in welcoming Tracy as she takes us forward and shows how the HIE can collaborate with providers.
Can you hear me? They tell me I have to either stay over there or have this on, so I have a tendency to wander around, so I'm going to go with this. And Buddy, I'm glad you didn't say we go many, many, many years back. I was at a meeting recently with someone who said, "You can't be as old as I am," and I was, oh, okay. So I'd like to thank you all for this opportunity to talk with you about ClinicalConnect. We like to refer, Buddy did tell you, it's a Western Pennsylvania Health Information Exchange, and we do like to refer to it as a collaboration of providers. Some people have a little bit of a misunderstanding that it is a UPMC Health Information Exchange, and UPMC is actually one of 9 founding partners. And interestingly, it was not UPMC who originally came up with the concept. There were 6 community hospitals in and around Pittsburgh that had been meeting since 2007, just around some commonalities like open heart surgery. And those CEOs, when the Federal High-Tech Act came around in 2009, and meaningful use became a reality, and the exchange of health information, actually approached UPMC and asked if they would be interested in collaborating on a health information exchange. So at that time, it was kind of offered up to quite a few of the health systems in Western Pennsylvania, and 2 others, Altoona and Armstrong, also joined at that time. So one of the first things they did was bring in a consulting firm to really look at how an HIE could be formed. That group came up with 2 potential models. And the first model is a rich model, and that's not just in terms of cost, although it was pretty costly, but it really started from the ground up with doing an RFP, building out infrastructure, starting with no data at all, and along with the whole thing of setting up marketing, legal services, insurance, benefits, etc. They also proposed what they called a lean model. And that lean model really leveraged UPMC's strengths around the technology. UPMC had been working since about 2004 with a vendor called DB Motion to develop an IDN and an interoperability model. If you're not familiar with UPMC, there are 19 acute care hospitals and several thousand physicians, all using electronic health records. They are standardized. There is one model for the acute care and one for the physician practices, but they are two different vendors, and we learned early on at UPMC that that needed to be integrated, and that's what they used the DB Motion interoperability for. So this lean model took advantage of that and allowed us to, I'm making noises when I get over there, allowed us to take advantage of 8 years of data that had been accumulated at UPMC. Over 6 million patient records sit in their repository. The other reason that UPMC was a good fit for this HIE is that of these 8 other community hospitals that joined in, referred a lot of their patients to UPMC. When we first started doing some analysis of overlaps of patients for the Master Patient Index, we are finding anywhere from 50 to 60% of the patients have overlaps with UPMC, which tells us that it really is going to bring value once we get it up and live. So in the CIO group that had been meeting for almost a year did agree to the lean model, and an outside law firm was then retained to construct bylaws and data exchange agreements and a member agreement for CCHIE. So in 2011, ClinicalConnect was established. I joined the team in August. The member agreements were signed in July. So we're a fairly new organization. We did establish a 503c nonprofit and created a board of directors, with the first meeting occurring in September. And each of the founding members has 3 representatives on the board. Their CIO, a senior executive, and a physician leader. And officers of the board, as listed up there, were also elected at that first meeting. In addition to electing officers, we established some subcommittees. So there's a privacy and security subcommittee, which developed the data exchange agreement and the HIPAA business agreement. We have a membership agreement and a finance agreement, a finance committee that established some just concepts around how we were going to continue to market this to additional providers and additional health systems. And we also had a quality committee, which is comprised of the physician leadership, and that group worked on establishing some of our quality indicators and benchmarks that we plan to use. The true governance on a day-to-day basis is handled by an operations and oversight committee, which is made up of all of the CIOs. I meet with them on a weekly basis. I like to say I have like 9 or 10 bosses. But we meet on a weekly basis, and they set priorities. They establish any issues, decide how critical the issues are, and where they fall in terms of our rollout plan. So this group is truly responsible for the operational oversight of the group. So these are the founding partners, and if you're not familiar with the Western Pennsylvania area, they really do cover a wide spectrum. We have several of them, St. Clair, Jefferson, and Washington, that sit in the southern region. Excella and Altoona are over to the east of Pittsburgh, and Armstrong, Butler are sort of north, and Heritage Valley is to the west in the Beaver County area. And then, of course, UPMC, as I said, has 19 different hospitals in that same region. So we cover a very wide geographic area of Western Pennsylvania. So one of the things that was established at that first board meeting was our mission, which is to develop a sustainable network in Western Pennsylvania. And the vision is really around providing information to the care providers. We want that information to be out there where they need it, when they need it, and in a very consistent and reliable manner. So some of the benefits that were established by that initial meeting of the quality group, and we tried to do this in a way that we all know that reducing adverse events, medication errors, eliminating duplicate tests are very great goals, but it's going to take us a while to build up enough data to really achieve that. So early on, our main benefit is to allow us to have good searchable health information available at the point of care. And we want to enhance the quality, reliability, and continuity of the healthcare delivery so that the providers aren't waiting for paper data to be exchanged. We also came up with some guiding principles, again, around coordination of care and having a very patient-centered model that came up a little earlier, and to facilitate access to the data across the continuum of care. We also wanted to build on our current investments. So all of the partners that in the initial rollouts already have an EHR, and we want to leverage that EHR. And we agreed to start incrementally. And this is one thing I learned very early on, that you could take on a huge amount of goals and things you want to do, but I think you'll just kind of fall over yourself. So we're starting very slowly by using a continuity of care document to populate our clinical database. And a key principle is that we wanted to help everyone achieve and maximize their meaningful use incentives around the exchange of information. So I just have a couple slides here about meaningful use, which I'm sure everybody in this room doesn't want to hear about anymore. But as I'm sure you all know, the stage 2 requirements, the comment period ended recently, and there should, hopefully by later this summer, we'll have more detail around it. But it really did focus a lot on the exchange of information. It is proposing a much more robust model with some very strict guidelines around numbers and percentages if it passes in its current form. So we are going to focus at ClinicalConnect on 3 pieces of that, and that's the communication, that whole transition of care concept, and also the public health measures. So the proposed ONC certification is to use clinical document architectures. I don't want to get into all of the technology with everybody here, but it really helped affirm our decision to use the CCD as our standard for exchanging clinical information, because it does seem to be the way that the ONC is recommending we go forward. Another key piece of it is the direct exchange project, and we are in a position to use that. We haven't made a definite commitment to start doing that at any time soon, but it is available from the vendor that we've selected. So real quick, the previous meaningful use requirements were pretty kind of not too structured. They just told you to connect to 3 external providers. And in stage 3, they were talking about 30% in your primary referral network. The most current proposed regulations are much more robust and are saying that providers of care have to provide a summary of care record for more than 65% of their transitions of care. And further, that 10% of those have to be electronically transferred, and they're now specifying that they have to go outside of your organizational affiliation and to a different certified EHR technology if they pass in their current form. One of the good things I felt was that they now have content proposed. The previous regulations were very open as to what needed to be in that transition of care document, but it's very specific now. So public health is another area where the ONC is really recommending that HIE step in. So for example, in the state of Pennsylvania, stage 2 is going to require that immunizations be submitted electronically, and rather than hundreds of physician practices and hundreds of hospitals building an interface to the state, they would really like the HIEs to handle this. So we are planning to help our members do that. Provided they get them to us in a CCD, we can then send them out to the state via that interface that's required. So this is a picture of what our model looks like. On the right-hand side represents UPMC. So as I mentioned, UPMC has been using DB Motion for their interoperability platform since about 2004. So that database on the right is being fed. At the bottom, there are two primary vendors at UPMC. One is Cerner for the acute care electronic record. The other one is Epic in the physician practices. And they're feeding all of their data in via discrete HL7 interfaces. They have about 40 interfaces that feed meds, problems, allergies, labs, documents, all sorts of data into that repository. As I mentioned, it has about 6 million records in it right now. Up on the top represents how they view the data. From within the two EHRs, they actually have, it is CCAL Centillion enabled at UPMC, so that while they're in the EHR, they can then launch out and look at the interoperability engine to see any data that is not in that same EHR they're in. UPMC is currently working on what they call more of a push delta technology that would allow them, while sitting in the acute care or the ambulatory EHR, a little box comes up and tells them there's data available. It's in its early stages, but seems to be showing a lot of promise. So the left-hand side represents what we're doing with ClinicalConnect. So we have established a totally separate node or instance of the DB Motion platform on our side. And again, we are going to be bringing data in from our member EHR, both their acute care and their physician EHRs. But we are doing the clinical data via a CCD, a continuity of care document. It's a discrete XML formatted file, which DB Motion does a very good job of parsing it out and actually storing the data discretely. They have normalization and software based on vocabularies, such as LOINC for lab and ICD-9 for problems. And that allows us to normalize the data, so regardless of which partner or the UPMC data, it can all be displayed together, because it's linked up via this vocabulary encoding. So we will be bringing in our clinical data via a CCD, and then we are also doing registration ADT feeds for all of the demographics. Then on the top, our partners or our members will only have access to the database via their own EHR. So we are not standing up an open portal where people can search, and we maintain the security. We have put that, left that responsibility back with each member, so that when that clinician or person logs in to their own EHR, the assumption is that they're permitted to view those patients and they have access to what they should have access to. Once they've selected a patient, they can then do it's a SAML launch. DB Motion calls it a smart launch. It actually sends a transaction to us with the patient identifier and the name of the user, and then we just open up the chart to that patient. It's really, as I said, serves the purpose of allowing each member to control the security and what that user can do. But it also eliminates the step of the user having to log into another system and do another patient search. When they launch, within seconds, they're right into that chart within our HIE. Now, the HIE data is not stored on the UPMC side, and the UPMC data is not stored in our node. It's a federated model. So when the query comes in, we go over and get the data from UPMC and bring it back, and then when they leave, it's just gone again. And on the UPMC side, they come over and get the ClinicalConnect data and bring it over to be displayed, and then it's gone again. So it's a federated model which allows us to maintain the two separate databases and two separate security models based on the fact that UPMC is an IDN and has different levels of access than we're going to offer on the HIE side. So it's a little bit of a complicated picture, but basically what it looks like is the clinician logs into their own EHR, they select the patient, they click a link, and the patient is displayed in context in our HIE DB Motion node. And what it looks like, this is the summary view in DB Motion. And there's just one example there, if I could find the pointer. probably should have done this before. Can't find it. But under the encounter there, the second row, the first row is Heritage Valley, and the second row is University of Pittsburgh. So all of these screens, when you dig into them, you'll be able to see the source of the data and whether it came from UPMC or whether it came from one of the other member hospitals. So this is just a summary screen, but then you can dig into to all of these to get much more detail. This is just the first screen they see. And as you can see, our focus for now is going to be on encounters, problems, allergies, meds, immunization, labs, and documents is what we're offering in this first phase. We also had, as I mentioned earlier, a privacy work group, or actually subcommittee of the board, and that group put together some standard data exchange agreements, which include a HIPAA business associate agreement and an addendum to the notice of privacy practices. So each member maintains their own NOPP, notice of privacy, and then we created an addendum to that that states that the data is now going to be shared with an HIE. Our HIE is a business associate, which covers us on all of the HIPAA requirements. And we have a staff member on our team who actually is devoted to all of the compliance, privacy practices, and will be doing all of the audits and the monitoring. Our data exchange agreement, again, includes the standard HIPAA business associate agreement, the NOPP addendum, and it was developed by the privacy work group and approved by the board and reviewed by an outside counsel. Some of these things took a really long time. So we're past it all now, and I'll be telling you we're getting ready to go live. But it was hard to get everybody to come to agreement on things and to establish that level of trust. That is definitely a tough sell. Our consent model was also part of the data exchange agreement, and we landed on an opt-out approach. So if you're not familiar with that, that means that the data is exchanged unless the patient specifically says they do not want to participate. So our data exchange agreement states that we will get the data into the HIE regardless, but we don't permit it to be viewed if the patient has elected to opt out. So our data exchange agreement at this time only permits the exchange of data for your standard TPO consent type criteria. And when some of the people have talked about analytics and data mining, which are certainly things that we want to do in the future, but for the time being, we are not permitted to use it for that, and the board wants to revisit that once we've established more data in the database and to bring back some specifics of things that somebody might want to do. There definitely were challenges with the consent model. Because we elected to do what we called the lean model, I don't really have a customer service center yet for my health information exchange, so we could not manage consent at a central point. So we have each of our members or our participants are capturing that consent in their registration system, and it comes to us via that ADT interface. The challenge was keeping track and testing the things potentially coming all different ways and laying on top of each other. So we have an MPI, I don't think I mentioned that, which is the IBM Initiate product, and the Initiate is where the consent is stored and maintained. And we always look at the last consent flag that we received, whether it's a yes or a no. So the patient can choose after they've already been in to opt out and vice versa. So a little bit about our implementation. I am really pleased to say that we are going live in about 2 weeks, cross your fingers, with our pilot, which is the Heritage Valley Health System. They are going to be sending us, and have been, we've received somewhere in the neighborhood of about 30,000 CCDs from them into a test environment, and it's been working very well. with the Federation over to UPMC. So they are the only ones who will be sending us the CCD initially, because we do want to pilot it for a little while. And we have successfully, as I mentioned, integrated that with the UPMC data in the clinical views. And during the month of June, 4 of the 8 members will begin to view the data. We have 2 of them going live the second week of June and the other 2 later on in the month in June. And we are in the process of working with the remaining partners to view by September. There's 1 or 2 of them that are in the middle of CPOE implementations and EHR implementations and have asked us to hold off until later this year. But we hope to have them all viewing. Just again, what we're proposing to include in our continuity of care document are encounters, medications, allergies, problems, immunizations, lab results, and we're starting with a very limited document set just to get started, and then we intend to expand that. We want to focus on discharge summaries, radiology reports, and pathology. And as I said, we plan to expand, but we needed to start somewhere. Future, what we're planning to do in the future is we are now taking, we actually had a retreat about 2 weeks ago with our CIO group and have decided to step back and actually start working in earnest with some of their EHR vendors on what their capabilities are going to be around the CCD. We are finding that some of the vendors, we are asking for the CCD to be pushed to us at the time of discharge, and some of them are just not capable of doing that right now. So we want to take a little bit of a break. We're going to go back and work with some of the vendors to see who the next candidate would be to do a CCD exchange. But then we also are working on piloting an outbound CCD. We have a few, one of the members is very interested in doing a query type transaction instead, where they ask for the data and we push a CCD back to them. They plan to then take that data, parse it, and store it in their own EHR. So we're working with one of our members on that. We are also working to add some additional hospital systems, other healthcare providers. We've had discussions with long-term care facilities, and we're also looking at possibly doing something with Quest or LabCorp, one of the lab vendors. We are planning to connect to other health information exchanges or possibly the new HIN, and I know Alex is here somewhere. Where did I? Over there. We participate in the eHealth Collaborative, so we're hoping that the eHealth Collaborative community shared services model that's being put up will help us to connect to some of the other HIEs and eventually also to the new HIN. I did mention that we were looking at doing the public health reporting of immunizations for our members if they need us to do that. And we really want to focus on helping them achieve meaningful use stage 2 by helping to deliver their transition of care documents back and forth between separate corporate entities, whatever the rule is. And then again, from a future perspective, I mentioned the Pennsylvania eHealth Collaborative Community Shared Services model, which would have us pushing data through that channel to get to the new HIN and some of the other HIEs that are forming across the state of Pennsylvania. We also could probably do that on our own, but we're really going to wait, and we want to participate as much as possible with the state on this. So I actually finished pretty early. So I went through that pretty quickly. Questions?
Tracy, how are you planning to connect to independent providers that aren't part of UPMC, if there's any of those left? But
wait, I have one here. So
good.
We're actually, if you do you mind, Jim, if I? Jim Troop is with the Pediatric Alliance in the Pittsburgh area, which is a private group of physicians. Now, they do have an EHR, so we've been working with Jim to possibly bring them on as one of our first private entity physician practices. They're using NextGen, I believe, and we'd like to try bringing them on. After my many years at Children's, I know that for some reason, pediatrics are they're really into sharing data, and they are a very, very collaborative group. And I think that Jim is one of them, and there she is, Sharon, from the Children's Institute, is also interested, and both of them are currently under review of contracts to join. So we're not restricting it to hospitals and affiliated physicians.
Tracy, in your opt-out model, is that an all or nothing, that the patient cannot shield particular
Yes, at this time it is pending the proposed legislation in Pennsylvania, which I believe maybe Senator Fulmer will be talking about later today. At the current time, I can tell you that no one is sending us mental health or substance abuse data. They have chosen to keep that out for now, but we will have to address that if that requires a separate consent in the future.
Tracy?
Yes.
You mentioned about you're just thinking now about direct. Do we have a means by now to test both the concept of encryption, authentication, and authorization across your network? And are you able to eliminate duplication of record?
We haven't addressed the duplication issue yet. So what my CIO governance group has asked us to put the direct project aside for the time being until right now, they really feel that needs to come from within their own EHRs. They don't think that the physicians really want to step out of their current EHR space over to the HIE, and then within the HIE, they would actually at the current time have to actually say, send this to so-and-so, which they don't think they would be very compliant with. Our vendor is looking at having a lot more functionality in 2013, depending on meaningful use stage 2 requirements, that would allow us to build a rule that says when you get a discharge document, push it out. And then we would have a physician directory that would tell us if that physician needed it pushed to a direct address. I'm sorry? Yes, and that's another service that the eHealth Collaborative is looking at providing, a HISP-type service.
So being a pediatrician, I'm going to ask you the tough question. What are you doing about adolescent privacy from EHR to EHR through a network?
Yes, another big area of privacy. So at the current time, we have no data in the I'm looking, it's not up there anymore. The UPMC node of DB Motion, we do not push the adolescent medicine records there. So it's how we're getting around it for the time being, but that is going to be just the same concept. We're going to have to establish.
I imagine you mentioned about the your current limitation with centralized consent. If you do opt different levels with behavioral versus standard, then you will need to address that, correct? You can't. Yeah.
Depending on what that final requirements are, but if it requires a second level of consent, that's going to become even more difficult.
And we've done that in other states, and it doesn't work on a local level.
Go ahead. Thank you. Thank you. Accountable care organizations in Pittsburgh, I'm not sure what the current state of that, but how do you see ClinicalConnect supporting the success of ACOs or interfacing?
The continuity of care document, is that real time? What's the turnaround time? And I'm over here.
Oh, I'm sorry.
That's okay. What's the turnaround time? I'm now a patient. I'm looking at your dashboard. I'm also receiving the clinical continuity of care document. What's the turnaround time as far as, is it real time or is it 30 days data? How old is it?
Oh, how, the depth of the data?
Well, the frequency, like how often do you transmit?
Our current model, we're doing the CCD upon discharge, and that would be from an inpatient discharge, ED departure, and I think most places are doing it 2 days after the outpatient visit is what they're planning to do in their model. So on the ClinicalConnect side, that comes to us, and it's very quick, but it comes to us after discharge or after depart. It is not real time. On the UPMC side, they're doing real-time interfaces, so it is real time. But on our side, it's about, depends on, you know, the departure. As I said, the ED departure, it could be the next day. But the depth of the data, we are doing problems, allergies, meds, and immunizations are at the person level. So when we get that continuity of care document, all of them are in there. Labs and documents we're taking for that specific encounter. We're not trying to pull all the labs that that person ever had done.
Where might patient portals fit in the model? Would it be at the HIE or at the member level?
At this time, the members have elected to have the portal at that level, and we are not planning to put up a patient portal model at this time. It's not in our roadmap for the next year or two.
But it would be a portal into the whole HIE data?
At this time, we would have to lay something on top of it because that is not functionality that our vendor provides and from a patient portal perspective. So we would have to put something on top of it. So we have elected to just not make that part of our strategic plan at this time. Many of the organizations already have a patient portal, our current members.
Hi, you may have already touched on this, and I might have missed it, but as you go forward and add more participants, do you foresee or worry about that some of them, especially the larger ones, might connect just into the NWIN or even the state, the eHealth Collaborative network and not be part of ClinicalConnect on a more local basis? And if so, how might that affect your financial business model?
Yeah, and I don't, my impression of what's going on at the state is that the state is never going to have a repository that somebody can go and get data from. The community shared services model that's being proposed would allow us to pass through to another HIE or pass through to the new HIN. The services that they're looking at are things like physician and provider indexes, possibly a patient index with consent, and I think I'm getting this right, Alex, but to actually have a repository that someone could go to is not in the state model at this time. Now, I don't know if the new HIN is really looking at that from that perspective either. It would probably, I think, direct you to where the data is at some point, but I think that's pretty far off to be realistic. Our business model, which I didn't have any slides about, but our business model is to charge a membership fee based on each hospital's or each health system's operating revenue. We have a formula we use. So we have commitments right now for the next 3 years. And actually, it's like a 5-year period that they've signed up for, but they do have the ability to say that they no longer want to participate. But I do think that the value hopefully will prove itself, especially when we get to the point where we're pushing the data and it's actually more in their own EHR environment or their own workspace. I think the value will be there. So, remains to be seen, but I think that's our intent.
Okay, I think that I'd like to ask everyone to thank Tracy for her excellent presentation. And as you all can see, there's a lot of action and activity that's going on here in the state. We are about to go for our lunch break, so a couple of things that I'd like to mention to you. One, outside we do have boxed lunches, and at 12 o'clock we are going to have our keynote speaker, Paul Lee, who's just come in from Washington, D.C., to give us what he says will be a provocative discussion on what's happening on Capitol Hill. So please do not miss that discussion. That will start at 12 o'clock, but we ask you to bring your lunch back here, and we will work through lunch. It'll be food for thought. So again, thank you, Tracy, and we'll see you back in 20 minutes.